Okay, hi, it's Richard Gould. I'm an Associate Medical Officer of Health with York Region Public Health, and I'd like to welcome you to this very interesting presentation. It should be very helpful for you in terms of getting more information about the vaccines that are available and helping you to communicate the information effectively to your patients. As you know, recommendations and support from a healthcare provider are extremely important in terms of building confidence and support for immunization among patients. So I think you'll get a lot of answers here and we'll have an opportunity to ask questions that will be able to help you out with this. And without any further ado, since we're a bit late, I'll hand it over to Nancy Wilson, who is the registrar for the College of Pharmacists in Ontario.
Great. Thank you so much, Richard. And I just want to start by saying South Lake Hospital, we heard you loud and clear regarding this vaccine confidence and using positive wording as opposed to vaccine hesitancy. And we've made changes in our slide to reflect that, but you have to forgive us. We may slip back every once in a while, okay? So I just want to say that first. I'll be moderating the discussion today, but I want to take a moment first to introduce our speakers, our key panelists, and tell you a little bit about them before I hand it over. So I'll start in order of speaking with Dr. Kelly Grindrod, PharmD. She's Associate Professor at University of Waterloo School of Pharmacy, and she is also the Ontario College of Pharmacists Professor in Pharmacy Innovation and the lead for the Waterloo Region PHU. Second up will be Dr. Gerald Evans. Gerald is actually chair of the Division of Infectious Diseases at Queen's University. He's also editor-in-chief of JAMI, and he sits on the COVID-19 Science Advisory Table for our province. And last but definitely not least is Dr. Cora Constantinescu. And Cora is a pediatric ID specialist at Alberta Children's Hospital in Calgary. She specializes in vaccine confidence and actually has the largest clinic here in Canada. So that's our panel today. We also have with us, when we move into the questions, Dr. Dan Warshawski from PHO here in Ontario, and Dr. Jia Hu from Alberta, who actually started, he's a mastermind behind the entire 19 to 0 movement. So they'll be there for us when we move to the questions. So with that, let's get moving. First slide, please. So today, in terms of the objectives, we'll be covering off three different things. First of all is going to be the vaccines and the ones that are approved for emergency authorization here in Canada. Secondly, we're going to be going through the contraindications and precautions, and Gerald will actually be talking about some of the latest information that's out there as well. And then we will be talking about vaccine confidence, and Cora will be taking us through all of that and what it is that's out there around vaccine confidence and various frameworks that could be used in your practice to be able to assist you in having the conversations with your patients. Next slide, please. This slide really just gives us a bit of a snapshot of where we are today, and actually it's not today, it's as of February 27th, because this information is taken from the federal website, and this is the latest information they have is to the end of February. And so at this point in time, what we know is that over 2 million doses have been administered here in Canada, and Northern Canada actually has vaccinated the highest number of their population, with Quebec and PEI coming next. We do understand, though, that over the next few weeks, supply will be ramping up, and as PHUs get the supply, we will start to get the numbers increased here in Ontario. So with that, I'm going to hand it over to Kelly Grindrod, and Kelly's going to start talking to us a little bit about the various vaccines here in Canada. Over to you, Kelly. Next slide.
Thank you. So I know there's a lot of folks on the call who probably have been reading a lot about this already. You're also probably fielding a lot of patient questions. You may not be specifically a healthcare provider, and you may be also just fielding questions as kind of an intermediary or trying to figure it out. So I'm just going to take you through a handful of slides and just give you kind of like a Cole's Notes version on what you need to know about the vaccines right now. So this is just a primer on them. So next slide. So the first and foremost, in December, we got the mRNA vaccines that came out. There's 2 mRNA vaccines that are now approved for emergency authorization in Canada. There's the Pfizer vaccine that we have, probably most of us have the most experience with, where you have 2 doses scheduled 0 and 21 days. And then this research was done in people over the age of 16. And so we see, this is the youngest that the vaccine trials went, we see over the age of 16, we're looking at there. So Moderna is one, we're getting more of it now, and this was generally kept in some of the central public health units. Now it's starting to spread over the rest of the province. It's also an mRNA vaccine, a little bit easier to work with than Pfizer. This is also a 2-dose schedule, 0 and 28 days. The trials were done in 18 and older. Next slide, please. So what are the mRNA vaccines? So they give instructions to our cells, ribosomes, to make the spike protein found on the surface of the COVID-19 virus. When I do media interviews on this, one of the things I notice, people are now following vaccines like they follow sports. People I'd never expect to know what a spike protein is can tell me all about the spike protein. Spike proteins are recognized by our immune cells, and then you have antibodies that are made against it. So every minute of every day, mRNA is used in our body to make the proteins we need. This is actually using a very normal, natural process to produce what we're finding is a very effective vaccine. Next. So how effective are they? And most of you would know this because this was the news when this came out. This is, the answer is just better than expected, period. So with Pfizer, there's 40,000 participants in the trial, and you have 95% protection from having the disease. That's any sort of symptomatic illness. For Moderna, the great thing was when you're seeing multiple vaccines coming out using these technologies, it's about the same, 94.1%, which also gives us confidence that these are pretty true efficacy numbers. And the really surprising thing, as a lot of you would know, is that this was similar across race and ethnicity. That would be expected. We wouldn't expect a difference across race and ethnicity, but age, there's a difference in age. And the race and ethnicity question is more reflective of the fact that these trials actually had more diverse populations than we have typically seen historically. So it was kind of good news on both those sides. They appear to still protect against the circulating variants as well. Next slide. So there's the SIREN study that you might want to take a look at when this webinar is done. It's a prospective cohort study done when the B117 variant was the dominant strain in the UK. And they found that the vaccine coverage for the mRNA vaccines was 89%. The healthcare workers were tested every 2 weeks via PCR and serology, regardless of their symptoms. And they found that the infection risk was 1 dose decreased risk of infection by 70%, rising to over 85% after the 2nd dose. For symptomatic COVID disease, people over the age of 65 or under the age of 65 had an overall effectiveness of single dose that was around 72% 3 weeks after the 1st dose and 86% after the 2nd dose, so 14 days after the 2nd dose. For people over the age of 80, 3 weeks after the 1st dose, they had a 57% effectiveness, and this rose to 85% after the 2nd dose. So this is quite comforting to knowing that these vaccines, even as in Ontario, we face this variant becoming one of our fast-growing variants, that we should hold on to some of the efficacy even with the mRNA vaccines. Next slide. There's also the vaccine rollout in Israel, which many of us are following for how they've done so well. So there's 2 groups of almost 600,000 people, matched vaccinated and unvaccinated pairs, and it maintained effectiveness across age groups, including those over the age of 70. Now, what's really interesting on this table is you'll look on the first column, you've got your time period of 14 to 20 days after the 1st dose, 21 to 27 days after the 1st dose, and 7 days after the 2nd dose. And along the top, you've got asymptomatic infection, symptomatic illness, hospitalization, severe disease, and death. And so what you see is you start to have some effect in the first 2 to 3 weeks, somewhere around 50% for asymptomatic and symptomatic illness, 75% hospitalization, 62% severe disease, 72% death. But over time, once we get into the 3 to 4 week period, those numbers are rising, give or take 10% or so. And once you get about 7 days after the 2nd dose, those numbers are going up into the high 80s and 90s. So we see that the immunity starts for a number of people in the first 2 to 3 weeks and continues to grow over time and with the added dose. Next slide. So there's also this preprint for Pfizer and AstraZeneca in Scotland. It was a prospective cohort study of 5.4 million people looking at the effectiveness of preventing hospitalization after one dose of each vaccine. The effectiveness showed that vaccine effectiveness peaked at 28 to 34, or day 28 to 34 post-vaccination, and the highest effectiveness after the first dose of Pfizer was 85% and 94% after AstraZeneca. Next slide. So let's talk about the vector vaccines. Those are the ones in the news right now because, the last couple of days we've seen the announcements of these are the ones, we have a big shipment coming in. They're going out to all these pilot sites, both pharmacies and family doctors' offices around the province. So next slide. So we've got the AstraZeneca one. That's the big one that we're talking about. It's the adenovirus-based vaccine, non-replicating vector. It's 2 doses like the mRNA vaccines we've just talked about, 4 to 12 weeks apart. The trials have almost 24,000 participants, and you would have probably heard some mention of this, but it was across multiple countries, Brazil, the UK, South Africa. The 62% efficacy refers to any illness. And they say there's also this 90% of those in the lower dose followed by a standard dose. You have to note that there are 2 different manufacturing sites. There's one in the UK and the EU. There's different viral particles in each, so one had almost twice the amount of the other. And it seems that the lower dose followed by the higher dose combination may show higher efficacy, but this is actually postulated to be due to the increased duration of time to the second dose. Next slide. So what is the advantage? Well, it's easier to store. I'm helping set up a clinic on Monday with Pfizer, and Pfizer is so fragile, but I kind of joke, I could throw AstraZeneca across the room and still use it. I mean, it is completely different to implement this vaccine. It's 6 months in the fridge versus 5 days for Pfizer vaccine. It's much easier to scale up it may be easier to scale up manufacturing, and this could contribute to many more Canadians getting vaccinated. It's still shown to protect against disease severity and death, and those numbers are quite a bit higher. So we've got the 62% of efficacy for any illness. We're getting very, very good efficacy, well over 90% for severe illness and hospitalization, approaching almost 100%. And there's flexible timing to the second dose, which is also very useful when we're working with large populations. Next slide. So Johnson & Johnson is the one that we've all got our eye on as well, because this would be the first single dose vaccination. And you can imagine there's a lot of reasons with a lot of populations why that's going to be critical. So the trials, there's the global phase 3 ensemble trial, which is 28 days after vaccination data. And so its safety and efficacy are based on about 43,000 participants accruing 468 symptomatic cases of COVID. It's 72% effective in the US, 66% overall at preventing moderate to severe COVID-19, 85% effective at preventing severe illness and death, 72% in the US, 66% in Latin America, and 57% for the South African variant. And no allergies were noted in the trials, which is also helpful given that this is a topic of concern with the mRNA vaccines, even with the mRNA vaccines, the risk of allergy is very low. Next slide. So I'll turn this over to, I believe, Gerald now.
Thanks very much, Kelly. So let's talk a little bit about adverse events following immunization, because confidence in vaccines a lot of times is circling around the whole issue of vaccine safety. So let's go to the first slide. Next one. So what are the sort of common side effects? Whoop. Back one, thank you. What are the side effects of the COVID-19 vaccines? So as a recipient of one of the vaccines a couple of weeks ago, I can tell you that a considerable number of people have a sore arm. Tiredness and headache has been well described in a percentage of people that we would consider significant. I didn't actually experience those myself. And some people will actually get muscle aches, chills, or a mild fever. But the really most common thing that people notice is a sore arm, and those are related to the reactions that are occurring at the injection site, and they do improve very quickly. I can comment personally that my sore arm disappeared really 24 hours later and I was back to normal. Next slide, please. So what should you remember about the side effects of this vaccine? So we're talking mostly about our experience with mRNA vaccines at the moment, but about 8 in 10 people complain of a sore arm, but only about 1%, 1 in 100 actually complain that the soreness is so severe, you know, that they really, really noted it. It would be very similar to vaccines that many of us have received in the past, including our flu shots and for older individuals who have perhaps had Shingrix or Zostavax. About 5 in 10 people, about 50%, will complain of a bit of fatigue or headache, but only about 1 in 10 have reported that they actually took an analgesic, whether it was something like ibuprofen or acetaminophen to relieve it. And really, it's important to remember that those side effects are really the result of an expected immune response. When we activate your immune system by presenting at a foreign antigen, which is the spike protein that's created from the mRNA vaccine template or the DNA that's in the adenovirus vector vaccines, we expect an immune response, and that immune response is accompanied by cytokines and lymphokines that actually stimulate things like tiredness and fatigue and some fever and aches and pains and stuff. So those are all appreciable, showing you that the vaccine actually is working. And some people notice those effects more than others. Next slide, please. We are following adverse events here in Canada. An adverse effect following immunization, and AFI, I guess, is the term. They're being reported and reviewed by PHAC. And of course, we have the Canadian Vaccine Safety Network, the Canvas program, which assesses vaccine safety immediately after the implementation of vaccine campaigns, like we're seeing now. So let's go to the next slide, which is actually, I think, probably going to pop up. I'm noticing some chat stuff, but I don't know if it relates. So this is the big thing that hit the news yesterday. Many of you, if you were watching your news, reading papers, going to websites, you heard about some countries in Europe as a precautionary measure, and really it should be underscored as a precautionary measure, paused their use of the AstraZeneca vaccine. Why? Because there were apparently 30 cases of thrombosis documented amongst 5 million recipients. And probably more importantly, the thing that made the pause happen is that there were some deaths that were reported from this thrombosis in countries like Norway, Italy, Austria, and Denmark. There was some mention made about the possibility of tied to a specific batch or lot of the vaccine. And so what actually happened in other countries, other than the ones that suspended the use of the vaccine altogether, is that they suspended use of that implicated batch, but there's no evidence yet that necessarily it's batch related. I think the important thing to underscore here is that rate of thrombosis, 30 cases in 5 million, is similar, if actually a little bit lower than what we see in the way of thrombosis in the general population. So I talked to my hematology colleagues, and they actually report that you have a sort of background of about 40 cases per 1 million, sort of if you want to put the 30 cases per 750,000 people. So in fact, this rate of thrombosis that's being seen in vaccine recipients is lower or at worst at the same levels what we'd see in the general population. So it's really important to understand whenever you're looking at reports about vaccine safety issues, is there may be some seeming association, but that association may not establish a causal link. And I think right now there's a lot of us who are very skeptical that this is actually being caused by the vaccine itself. And perhaps what we're just seeing is a lot of caution. And that would be important amongst countries where the vaccine has been approved for use, and just making sure that they can have some time to examine that safety signal. So that's the thrombosis issue. It may be, if I can quote Shakespeare, much ado about nothing. Next slide, please. So if we look at the monitoring in Canada real time, this is what we know as of late February in terms of adverse reactions. A total of 1,397 were non-serious, 194 were deemed serious, which represents only 0.011% of all doses administered. At that point, we had about 1,778,000 and some odd total doses administered to that point. So the experience with this vaccine is really that we're not looking at substantial adverse effects beyond what we might expect with any vaccine given to a large population. And remember, there's a select population in here. We are giving it preferentially, have been in congregate settings early on. These are elderly individuals, oftentimes with comorbidities. Next slide, please. So what about the precautions and contraindications to the COVID-19 vaccines? Let's move on to the next slide. What we do know is that obviously if you had a severe allergic reaction if during your first dose, you would not be administered a second dose of these vaccines. There are varying rates being reported, but you know, in the latest vSafe data from the United States, the sort of incidence of anaphylaxis, which has been primarily reported to be a mild form of anaphylaxis, not an overtly serious one, is actually very low, and it's probably somewhere around 1 in 100,000 to as maybe frequently as 1 in 50,000. And of course, we say to people, if you're allergic or hypersensitive to a component of the vaccine, be careful. So the problem is people always say, well, what's in the vaccine? It's mRNA, it's a lot of lipid, including cholesterol and phosphatidylcholine and other things, but it is suspended in a media containing polyethylene glycol and polysorbate. So I'm not sure a lot of people know that they're allergic to those things. PEG is pretty common stuff, and it's not a frequent allergy. Next one. So what about precautions? Well, we certainly don't want to give it to somebody who is suspected to have SARS-CoV-2 infection, and certainly not one confirmed at that time, and we would defer vaccinating them until they had recovered. If you're acutely ill, we are always careful about not giving vaccines because we know that acute illness is oftentimes associated generically with an impaired, reduced response to vaccine antigens that are administered. If you've received another vaccine in the previous 14 days, we don't want to give it to you. And again, back to vaccine science here, although we do give multiple vaccines to children and they do mount a good response, in adults, we kind of like to separate them out sometimes a bit because we think that we get a better immunogenic response if we separate vaccines by at least 2 weeks. That's just basic vaccine science. And of course, right now, we don't have data. It is coming. There are trials ongoing in children and even some emerging data suggesting, of course, that they're safe and effective in kids. But at the moment, we don't have the data in the current regulated and approved vaccines for administering to people under the age of 16. Next slide, please. And now I'm going to confidently pass this over to my colleague, Cora, to talk about vaccine confidence. So over to you, Cora.
Thank you, everyone. First, I just want to, I'm presenting to you from Calgary, and I want to acknowledge the land of Treaty 7. So this is the traditional territory of the Blackfoot Confederacy, the Siksika, Kainai, Piikani, Tsuut'ina Nations, Nakota Nations, and the Métis Nations, and all the Treaty 7 people who live in Southern Alberta. So it's my great joy to talk to you about vaccine confidence around this vaccine. Because I'll tell you a few things. Next slide, please. I keep on trying to click the next slide myself. Many things have changed over this pandemic, but the one thing that hasn't is that healthcare providers are still the most influential source of vaccine information for their patients. So recommendation from you is the most influential thing that your patient may get in terms of vaccine confidence. So, but when we address their issues around confidence, it is important to remember that, and I am paraphrasing this, people they don't reject facts because facts are untrue. They reject them because it doesn't, it does not, they feel they don't apply to them. And that's really important of how to morph the facts without changing the facts, but to make them personalized to that patient. And we'll talk a bit about that. Next slide, please. So here's where we are in terms of willingness to be vaccinated. This is data that was started off by Angus Reid in the summer. And now, as of January, about 60% of Canadians were willing to get a vaccine as soon as it was available to them. Next slide, please. And what are the reasons for some of this hesitancy around taking this vaccine? There are issues with confidence. Confidence means they may not trust the safety of the vaccine. That's really big. Despite what you've seen earlier in terms of miraculous performance of these vaccines, some people don't trust the vaccine works. There are also issues of trust between people and their healthcare providers and their health agencies and governments. Complacency is a big one. So if you don't perceive the risk of the disease being there, you're less likely to take the vaccine. Similarly, that applies to people who may not believe that COVID-19 is a significant risk of severity and death to them, But we've also found a group of people who feel they're so confident in their compliance with public health recommendations that they don't feel the disease is a threat to them and therefore they don't need the vaccine. So obviously, we'd have to have very different messaging there. Convenience is really important. So, issues around scarcity with healthcare workers, some are concerned they may get a reaction from the vaccine, like a sore arm or fatigue. They wouldn't be able to come to work the next day. They don't have sick days around that. So, these are all important. Calculation, really crucial. So, where do people go for information? We know that if you're vaccine hesitant, you're much more likely to go to a vaccine, to less trusted source of information, and collective responsibility. So here we are telling people that everybody should get the vaccine to try and protect the most vulnerable in the population. And you can see how people who are concerned about safety just don't feel that that resonates well with them. Next slide, please. And this is a graph that really shows that the more concerned people are around the disease, the more likely they are to want to take the vaccine. So that's still kind of a gist of the information that we should pass on. Next slide, please. Um, Now, healthcare workers themselves can have concerns around confidence around this vaccine. We know that about 76% of them are strong supporters, 17 are on the fence, 7 completely oppose the vaccine. About half of personal support workers were not confident, so they were hesitant around this COVID 19 vaccine. And specifically, if you're a healthcare worker of a lower wage, racialized, female, and part time, you're more likely to be hesitant around this vaccine. Next slide, please. When they look, this is all Canadian data. So when they looked at this, if you're younger, so under 34, visible minority, have children, lower household income than 40K a year, and unsure of vaccine safety, more likely to have issues with confidence. Also, to be completely opposed to vaccine, similar age group, believe the vaccines are harmful. So this issue of safety is really crucial, and more likely to work in construction or manufacturing. Next slide, please. Really important is to remember that our ethnic communities, and unfortunately people in ethnic communities, it tends to be a bit more vaccine hesitancy. There is a strong history of trauma related to medical experimentation, a strong history of trauma related to discrimination, and there's a lot of distrust between these ethnic communities, minority communities, and potentially health agencies and government. So important to acknowledge that when interacting with patients from an ethnic community. Next slide, please. So what do we know and how can we improve our communication? Next, please. So here are a few pointers on how you can improve communication in vaccination. Even before you address the concern people have, spend time to find some common ground with that patient. Because if they cannot relate to you, they're less likely to trust what you're saying. Keep your messaging very simple. So use simple numbers. So you can say 8 in 10 people are going to potentially have a sore arm, but only 1 in 100 are going to call that soreness severe. So again, simple numbers so people can remember this. And remember the gist of what you're trying to communicate. Don't get lost in the minutia of adverse events or administration because people make decision on the gist. So the gist overall should be the vaccines are safe and effective. Personal testimony is really important than anecdotes. So talk about things you know, because again, it goes back to that building common ground, being more relatable to your patients. Next slide, please. Um, a few points on how to tailor the message. So when you talk about vaccine confidence, don't talk about the vaccine as a whole. Talk about what's relevant to that patient. So for example, if they're a single parent, talk about how traumatizing being hospitalized as a single parent would be. to them and to their child. For people that identify with an ethnic group, acknowledge the historical harms of vaccines and medical experimentation that people have had to go through. Acknowledge that kind of trauma will shape their view around this vaccine right now, and try to point them towards local champions and support groups. And what we've seen over this pandemic is that we've seen a lot of local champions that come out and help people within a certain minority group, and highlight the community benefits. So, for example, especially around the Indigenous communities, you can speak on how COVID-19 differentially kills people in Indigenous communities. We seem to have more severity, more hospitalization, more death. Not only does it mean losing the older people, the elders, but it also impacts the culture and the language that these elders would pass on and teach and keep alive over centuries old traditions to their communities. So it has such an impact on the community. Next slide, please. Overall, the gist is this: vaccines work and they're safe. COVID-19 risk is significant. Even if you're not at high risk of death and hospitalization, each and every one of us has had to pay a price for this pandemic and what this has meant to our lives, whether it's in terms of jobs, economy, real estate value, whatever it is. And it's the way out. Next line, next slide. I keep on saying next line as if I'm dictating, so my apologies. Next slide. Thank you. This is good. Stay here. So I'm going to promote this Protect plan. So this is a little plan of how you can frame your communication with the patient in a way that you can, and I would say not even just the patient, but also your colleagues. I've been asked by so many colleagues decisions around, mRNA and AstraZeneca and so on. So how you can frame your communication in a way that helps build that common ground and trust, even and empowers you to have this conversation, even if you're not a vaccinology expert in COVID-19 vaccines. So here's how we start. The first part, the PR, stands for proactively starting the conversation and making a presumptive statement. You're assuming that that patient is going to go ahead and have the vaccination. So for example, you may say, have you heard we're getting over 1 million doses every week in Canada of the vaccine? That's proactively starting the conversation. Then you can say, I've just been offered this vaccine now and I cannot wait to get this myself. When would your time come? Or when are you going to book your appointment? So this is again assuming that they will go ahead and have the vaccine, versus a participatory comment, which is, are you thinking of getting the vaccine? That's participatory. Presumptive is, when are you going to get the vaccine? Then you're going to offer to share your knowledge. So this is where you engage them in the conversation, but also offer value from what you know. So you could say, I just had a chance to attend a webinar on this and I learned a few things. Can I share them with you? And then you're going to tailor the recommendation. So a big question is, if I'm between 50 and 65, this is the recommendation in Alberta. I know that in Ontario, over 60 can also get the AstraZeneca vaccine versus mRNA. So this is a common question. So how would you tailor that recommendation to them? You would say things like this. You'd say, you're between 50 and 65, but healthy. You're doing really well. Maybe you're a 61-year-old who's healthy. You don't have any comorbidities. Probably the risk of death is lower for you, but the risk of hospitalization is there. And the one thing that has been shown both in the phase 3 trials, but also in real world data, is that even one dose of the AstraZeneca vaccine decreases hospitalization significantly. We're talking over 90%. So the chance of hospitalization for you will decrease after you've had this one dose of the vaccine. So again, this is tailoring it to their particular concern in their own life. Then you're going to address whatever concerns that they've had, and then you're going to talk through a plan. So never end the conversation without going back to that presumptive part, saying, when are you going to see when are you going to book your vaccine? So again, trying to say, if you're in 1957 and earlier, you can book your vaccine today. So you're talking through a plan with your patient. Next slide. And I've already spoken through all about this. So I think the next slide is just an example of this. And next slide, please. And I think, thank you very much. We'll stop here and then we'll address some of your questions.
Great. Thank you, everybody. So at this point, I'm going to take it back over for a number of the questions. I would ask that people continue to put your questions into the Q&A, and we will kind of pick them off one by one. I'm going to start right now by asking Gerald to address two questions that have come up. One of them is with respect to the intervals, like how long does one wait between the vaccines, and what's that efficacy as a result of that? And the second question, Gerald, is around the pregnancy and efficacy of the various vaccines in those patients. So over to you, please.
Right. Thanks, Nancy. So on the interval issue, which is probably one of the biggest questions that's coming out now, I have to put it into two very significant issues. One is that you have to understand that when a regulator approves a vaccine, they approve it on the basis of clinical trial evidence that's given to them. With the two mRNA vaccines, the interval between the first and second doses was actually quite short at 21 and 28 days, respectively, for Pfizer and Moderna. Why did they do that? They did that so they could turn around results so we could know about whether these vaccines were effective very, very quickly. If they had gone with the traditional 3-month or 6-month second dose interval, you can imagine that we would only be seeing some data now, and perhaps not even that if they had gone further. So 3 months is a very typical interval for administering a second dose of any vaccine that's out there, because we know that the early response to vaccination from a first dose primarily gets effector cells, B cells, which make antibodies, T cells, which orchestrate that immune response, up and running quickly. If we give the next vaccine dose a little bit too close to that initiating event, then we're continually stimulating these effector cells. And what we really want to do with the vaccine to ensure a durable response is to get the immune response with the memory B cells and memory T cells, which remember and recall an antigen much further into the future. So actually, if you're a vaccine scientist and you know a lot about the immune response to vaccines, you really want to separate them out so that that second dose is stimulating these memory B cells and T cells so they get this incredible durable response. The other reason the interval was a bit short with some of the vaccines was they were looking at administering it to older individuals. We know that older people almost always have reduced immunogenic responses compared to young people. And as everyone knows, we've been really particularly targeting older people in COVID-19 because they suffer the severe consequences of the infection more so than those of us in younger populations. I guess I better be careful calling myself younger population at this point with my gray hairs. So that's really the interval issue. So if you know a lot about vaccine science, 3-4 month intervals are perfectly fine, and in fact potentially better than those short intervals, but the regulators who license the product are oftentimes stuck with having to continue to approve them based on the clinical trial evidence. The pregnancy issue is interesting, so I'll sum it up very quickly. Pregnant women have a great immunogenic response to these vaccines. Yes, pregnancy is a relatively immunosuppressed state, but it's very mild. If you're pregnant, you're carrying around a foreign protein in the form of the child that you're carrying in utero, but in fact, your immune response is good. The biggest issue that we've been sort of facing, and I've certainly had a lot of questions about, is what about safety in pregnancy? So the VSafe data in the United States has been very useful for that. They've reported out to late part of February, administration of the mRNA vaccines in particular to over 30,000 pregnant women. And when they looked at rates of adverse outcomes that might be associated with the vaccine, they in fact showed that the rate of those adverse events, whether it's a pregnancy outcome like miscarriage or stillbirth, or whether it was related to pregnancy complications like diabetes, eclampsia, and neonatal outcomes, in fact, those recipients who received the vaccine had virtually the same rates as you would expect in a background population of people who didn't get the vaccine, of women who didn't get it. So in fact, with a fairly large number of over 30,000, it's probably closer now to 40,000. The VSafe program has suggested very strongly that there is not an adverse safety signal when administered to pregnant women. So my advice when I'm asked as a physician, for a pregnant woman who says, I'm interested in getting the vaccine, is I say, yes, absolutely, you should go for it.
Great, thanks, Gerald. I'm now going to go to the question and answer screen here, and I'm going to start from the top and start moving down. So if anyone has questions, please, again, put them into the Q&A, I don't know, I guess it's called a chat, as opposed to putting in the chat box, because I'm not going to be looking at that. I'm going to be focused on the Q&A screen, okay? So if I could ask all of our panelists to please start their videos so everybody could see you, that would be great, and I'll be sending questions across. So the first one is, when do family physician offices get the vaccine, and if so, what type? I know that's more of a question for Dan. So Dan, can you perhaps speak to that a little bit?
Sure, happy to. It's a really good question. I don't think we have any solid number on yet when broader family physician role is going to happen. Obviously, the pilot sites have already opened in Ontario, and that'll be running over the next little while. Primarily, primary care at this point is going to be receiving AstraZeneca vaccine and probably eventually the Janssen product when we do get it in. I think for a broad rollout on primary care, we're looking probably later in April and May, when multiple family doctors and other primary care offices are going to have it. At this point, again, it's still up to the pilot to see how many places are going to be receiving vaccine.
Great, thank you, Dan. So the next question actually links back to the question, Gerald, about intervals. So I'm going to ask you to speak to it a little bit. It asks, what will the effect on dropout of virus resistance in months 2 and 3 and 4 after dose 1? And what is the effect on boost in immunity after dose 2 in the short and long term? I'm wondering if you can maybe speak to a little bit about the virus resistance. I know we had a slide on it earlier, but if you could just address that one, that would be great. You're on mute.
Yeah, I know.
Gerald,
I didn't get my microphone off fast enough to stop you from saying that. Anyway, my least favorite expression on Zoom is, "Oh my God, you're on mute." So I think the question is a little bit about variants and whether the vaccine's efficient after first and second doses. Lots of the data that we're gathering is in vitro. We do know that the current vaccines, in addition to obviously protecting against wild-type virus, do protect against B117. And B117 right now is the current variant of concern that is most commonly seen here in Canada, and less so the others. The in vitro data suggests that although neutralizing antibody titers fall for the B1351 and the B1128, which are the variants that arose originally in order South Africa and in Brazil, the fact of the matter is those antibody titers, the neutralization titers, actually remain very high and within what we would call a protective range. You've seen the data that Kelly presented on the use of J&J in South Africa, and to some degree some of the AstraZeneca data, and it does suggest that there is efficacy. So, you know, I think it's a complex question that was asked, which is what's going to happen between, if you were to acquire it between the first dose and the second dose. I would basically try and make it as simple as possible. If you're young, and when I say young, I'm sort of talking about if you're under age 50, the immunogenic response you get from any of these vaccines is going to provide a very effective protective effect. If you're older, that second dose may be a bit more important, and particularly those over the age of 70, to get that really high level that, if affected by a drop in neutralization titer effect from a variant, is going to get you. But really, I think I would kind of, at this point, put things aside. B117, you're going to get good protective immunity from any of the vaccines at present against that variant, in addition to the wild type strain that is circulating. So I think it was a complex question, and I'm trying to get at, I think, what they were talking about, which was what happens if something happens in the middle between the first and the second dose. The immunogenic stuff tells us second doses should be further apart. If you were really worried about a bad variant, then yeah, you might want them a bit closer together. And a lot of this, as everyone knows, of course, is being influenced somewhat by supply.
Great. Thank you very much, Gerald. The next question I want to pull up here is with respect to contraindications possibly for folks that are getting chemotherapy. There's a comment about methotrexate and one very specifically around chemotherapy, and I'm wondering if either Kelly, Gerald, or Cora could answer that one. Oh, I have a hand up from Kelly, so Kelly, over to you.
It's drugs. This is when the pharmacist comes in. So yeah, I think the thing is that, and we're starting to actually see, one thing that's been really helpful is when rheumatologists and other people who prescribe these immunosuppressing medications have actually reached out directly to patients to let them know it's okay to get the vaccination. For chemo, it's not the chemo per se so people with cancer going through active treatment, absolutely. The question here isn't about safety. Of course, this is about efficacy. When you're a bit immunosuppressed, you're going to have a harder time responding to the vaccination, but you're also immunosuppressed in the time of a pandemic. So the priority is getting you vaccinated as quickly as possible. The one group in cancer that we might be concerned about, and I can post a link to this in the chat, would be people going through stem cell transplant, CAR T therapy, where you're really obliterating the immune system. And so even giving the vaccination wouldn't necessarily have any impact. And so those cases, you may have to delay it simply because you won't actually respond to the vaccination at all. But those are exceptions. Like most people who are taking immune medications can absolutely be vaccinated. And I think the thing is too, logistically, we've got to get the whole population vaccinated, and we don't want to overcomplicate it. So, reminding people, get the vaccine when you can is a pretty critical step.
Nancy, I'll just add a few, just
one
one thing. So some groups have made recommendations on, there's a lot of questions on immunosuppressants, so maybe I'll take some of that. So overall, just like Kelly said, the issue here is not safety. It's trying to optimize your response to the vaccine in terms of immunogenicity or protection. So some groups have said a couple of things. One is, depending on what immunosuppressant you're on and what your underlying disease is, they talk to your doctor because they might be able to stop the immunosuppressant that you're on. Again, not from a safety perspective, but just to kind of give your immune system the best chance to go and respond. Some of the chemotherapy, some of the cancer experts have said, try to time it with chemotherapy to be a few days, maybe just before your next chemo. Again, not safety, but just to reduce your chances of, for example, having bleeding at the site if your platelets are really low, and trying to optimize your, the number of the immune system that you have before your next cycle. So it is worthwhile having a conversation in terms of timing, but get it as soon as possible available to you, because some protection, especially against hospitalization and death, is really crucial in these populations.
Great, thank you so much, Cora. Since you're on and you're in the pediatrics field, there's a question here on breastfeeding. And I'm wondering if either you or Gerald can take that one.
I've already typed something about that, Nancy. So again, the same thing, same as pregnancy. No contraindication there. Go ahead and have the vaccine. We don't know, but we postulate there is potential some transmission, especially in that third trimester across the placenta, of antibodies to the baby. Key things to remember is pregnant mom and baby under 12 months of age, both high risk for severe COVID disease. So protecting that population by ensuring you're immunized as a mom and now bringing it home to the baby is really crucial. No contraindications. Multiple expert groups have said go ahead and have the vaccine. You don't need to pump and dump either. So just go ahead and feed your baby as you would otherwise.
Great. Thank you, Cora. So I'm going to move now to a question that we have about long-term effects. And it speaks about stage 3 trials only in about 4 months right now, are only at about 4 months right now. I wonder, Gerald, if you could talk about the long-term effects around the various vaccines.
Are we looking at long-term immunologic effects or adverse effects you're talking about?
I'm sorry, it doesn't say. I'm assuming that it probably means, I'm assuming that they're talking about long-term adverse effects.
Yeah, so it's a great question. And when we have lots of vaccines and lots of people for a long time, we'll be able to tell you the answer. Right now, in looking at some vaccine recipients who've received it as early as December, remember we're just into March right now, there do not appear to be any significant signal that there are long-term safety issues with this vaccine. As you would expect, your immune system reacts, it develops its antibodies. If you get a second dose, it boosts that and may ensure durability of that response. And in fact, other than that, you would not expect to necessarily see any other long-term effects. I think that's an important thing to really mention, and I'm happy actually for Cora to maybe chime in on this issue as well, just simply because this is the sort of great unknown, right? When you don't have an answer for the question because we don't have long-term data, you can start to sort of mull over in your mind that there might be something. And it reminds me, unfortunately, a little bit about some of the things that people have talked about with our routine childhood immunizations, saying that there are things that go on later in your life that are related to it. But, you know, a causal link for those is pretty dubious at best. So, Cora, do you want to chime in there on the sort of long-term issues with immunization?
Yeah, people like to throw this out, and I'm not totally sure where this is coming from. I suppose it's just fear. But again, in other immunizations in children, there are no others that we correlate to long-term effects. Even the live vaccines, which can have an effect up to like 6 weeks out, like thrombocytopenia, things like that, we still don't worry about years out. And anytime they've looked at causation and correlation, it hasn't proved to be a thing. We don't see any long-term effects of these. And it's interesting because we don't ask that about anything else. So if you come in and you have a urinary tract infection and somebody puts you on Septra, nobody says, well, what's the long-term effect of being on Septra? We just see it. It's necessary, because if you don't, you're going to you need something to help your infection. And it's similar here. The other thing I do say is we don't know what the long-term effect vaccine is, but we sure know what the long-term effect of COVID is. We're seeing so many more long haulers of COVID now. They've even described it in children. There's even children long COVID. So, keep that in mind when people are worried about long-term effects. Sorry, I saw Gerald raising his hand again.
Yeah, and I'll just say that I'll just sort of point on that issue of long COVID, which Cora just raised. There's some interesting emerging data. I will say it's emerging. We don't have answers yet, but it appears that some people who have continued to suffer from some long-term effects after a natural infection with SARS-CoV-2, that they improve after they're vaccinated. So again, emerging evidence that really is sort of pushing us in that route, that maybe there is an immune regulatory function here. So yeah, if anything, I can't emphasize enough. I think that all of us have said the vaccine is really where you want to go. You do not want this infection. You want to be vaccinated and protected.
Great, thank you. So we have another question here that's asking whether or not COVID vaccine can be administered with other non-vaccine types of injection. They've specifically talked about Prolia and Zoladex, and I'm wondering if Kelly, you might want to start off on that one, and Gerald and Cora, if you want to add to that, that would be great.
Yeah, and I think it's really just to echo what Cora and Gerald have both said earlier too, which is that you're always focused on efficacy and boosting efficacy. And what can happen, what patients may want to do, is they can reach out to the prescriber of an immunosuppressant medication and talk about a potential delay of the immunosuppressant medication. And I think the key that we probably want to emphasize is, where possible, you don't want to mess with the vaccine. I think their supply is a real issue right now. It's hard to get a vaccination. People are registering, getting appointments. You really want to take away the barriers to them getting the vaccination. The easier problem to solve right now might be to delay treatment. If you can't delay treatment, and we're not talking about the stem cell and the CAR T therapy and all that kind of stuff, if you can't delay those immunosuppressing medications, you're better off still just going ahead with the vaccination. So it's about optimizing. It's about, number one, get it when you can. And if you have an opportunity to optimize it a bit, reach out ahead of time proactively, but don't delay while you're waiting to hear back from your rheumatologist, for example.
Great. Cora and Gerald, anything to add? No? Okay, so we're good. All right. One of the other questions coming up is with respect to the two vaccines, AstraZeneca versus the mRNA vaccines, and one, the efficacy and all of that. And there's some recommendations, of course, around that AstraZeneca being limited to those between 60 and 65 at this point in time, and those that are over that, they're saying to use the mRNA vaccine. So can you speak a little bit to that? I'm getting the biggest nods from Gerald, so I'm going to ask him to start, and then everyone else could jump in.
Yeah.
Gerald.
What's really great about questions about COVID vaccination is they just keep being the same ones over and over and over again. This is really important, and I'm gonna maybe let Cora eventually talk about vaccine shopping, because this is what it leads to, is this idea that there's a differentiation. I think first of all, it's really important to point out, when you look at those efficacy numbers which Kelly shared with us around the trials, different endpoints, different time periods they were done in, lots of other things that go into that sort of understanding. I will say that the AstraZeneca randomized controlled trial was a little messed up. They had some problems with dosing. That's why you had a low dose, standard dose, and then a standard dose group. And so it's hard to dissect those out. So the problem that you always get into, and I used to do a lot of drug evaluation, which Nancy will tell you about when I was chair of CED, as these are indirect comparisons. And really, if you want to compare, something, it's apples to apples and oranges to oranges, not apples to oranges. And that's where you get into this, well, I want the one that's 95, not the one that's 80 or 76. So, because you really can't do that. They're all effective. The big message I have is every single one of these vaccines has enormous protective immunity. Protective immunity is the immunity you develop that prevents you from getting a severe illness, therefore being hospitalized and dying. All of them do that, and they all do it at about a 99 to virtually 100% effect. Sterilizing immunity, which is the actual prevention of infection, there may be some differences coming out there, but again, you got to be careful comparing them because these are indirect comparisons. But there is good evidence from some of the countries that have rolled out vaccine early, Israel, and some of the stuff in the UK, that sterilizing immunity is pretty high too. It may be as high as 65 to 70%. And that's really great, because if I give you the vaccine, you can't get the infection at all, never mind getting sick, but just never get the infection, then we're going to see it roll out to something called transmission immunity, which is the reduction of transmission of the actual virus, which if, as a vaccine-y kind of person, that's I call the holy grail. Like if I give you a vaccine, you not only get it, you don't get infected, you don't get sick, can't transmit it to somebody, holy mackerel, that's the trifecta. So essentially that's where we're sitting. So be very careful with the comparison stuff, because that leads to this vaccine shopping stuff. And I'll just turn it quickly over to Cora, because every time I listen to Cora, I learn cool new things about vaccine confidence. And today it was understanding vaccine shopping. So over to Cora.
So first of all, let me just acknowledge that I think about this so much with my own parents, and who are unfortunately under 65, and it's so hard, and I totally see where people are coming from and why. Wouldn't it be I almost prefer nobody had offered any options to people, because this is what it's led to. At the end of the day, what I say about this is this: the reason this world has come to a standstill and our economy has halted is because of hospitalization and death. This is why this is not just a regular virus, is because it has so much hospitalization and death. And if we can remove the hospitalization and death then the specter of this death can lift away from our society. And all the vaccines that have been authorized are really good at preventing hospitalization and death. And to me, I tell you, when I'll just say this, I live with my mother-in-law and she's 77. And when she got the vaccine, that's exactly what lifted this sense that she's going to die of it. And then our mental health improved significantly. So don't underestimate the power of a vaccine that takes away hospitalization and death, which is why people are saying don't shop around and just have whatever vaccine is available to you right now.
Great. Thank you. Anything else to add, Kelly? You get the last word, and then we'll be closing down. Okay. So everybody, I'm hoping that we've answered pretty well most of the questions that have been coming up. A lot of them kind of overlapped on others. And so we tried to take as many of those questions as we possibly could. But thank you, everybody, for being here with us today. I hope that we were able to provide you with some information that will be helpful to you as you're working with your patients and also talking to your other colleagues across the board. Know that this session has been recorded. It will be available on the 19 to 0 website, and also we will try to make the slides available to everyone as well. On top of that, just to let folks know, is that there are little shorter videos that are being taped now, even as we speak. Some of them are done. Some of them are underway that will also be available on the 19 to 0 website. And we have them only in English at this point in time, but we are starting some work now to be able to provide them in French and also hopefully in other languages as well. So again, thank you all for being here. Thank you to all of our panelists. Thank you, Richard, for hosting all of this, and York Region for hosting all of this. And thank you, everybody, for all of the background work that was done, because we know it wasn't easy pulling all of this off, okay? Again, have a great day, everybody. Have a great weekend and stay safe and go and get your vaccine.